So before I continue on to the presentation for today, I thought I'd recap for last time. So I had the opportunity to present at a previous research exchange in November with a presentation entitled "A Consolidated Framework for Generating and Validating Synthetic Structured Electronic Health Record Data." The major highlights from there were we showed that we had a sort of pipeline to be able to generate structured data of multiple different types, in addition to being able to generate electronic health record data with realistic patterns of missing data. We consolidated all of this into an automated pipeline that took essentially a sort of raw data matrix of EHR data, trained a synthetic generator, generated synthetic data, and then validated that data in a report. And we applied this pipeline to 3 different EHR data sets from 3 different healthcare institutions to show proof of concept of generalizability. And that software package is posted in a public GitHub repo on the Innovate for Health website. So going on for today, I was going to concentrate on sort of comparing a couple of different techniques for creating synthetic electronic health record data. So I'll first outline the synthetic data generators that I'm going to compare. I'll then do a sort of qualitative comparison, in addition to describing a data set on which we'll do quantitative comparisons of these synthetic data generators, both in terms of realism and in the case of one of the generators to ensure that privacy is preserved in the synthetic data set. I'll end by giving a very abbreviated sort of user guide showing a couple of different stakeholders and possible case studies for synthetic data analysis and recommending the appropriate tool for those cases. And then just conclude with some highlights and sort of ongoing work. So the overall motivation for synthetic data generators for electronic health record data is to help increase accessibility and speed innovation using electronic health record data for clinical data science. Of course, as many of us know, EHR data access is limited in order to preserve patient privacy, which is of the utmost importance. However, synthetic data provides a sort of compromise in terms of being able to create data that resembles real data in its sort of relationships and its format and correlations among its features, but actually does not correspond to any records within any real data set, therefore allowing for realistic data to be distributed more widely without the same concerns about patient privacy as real data. There are many potential uses. Some of the uses that I'll explore today in the comparison study are doing, if the synthetic data is realistic enough, is doing exploratory analysis, looking at summary statistics across synthetic patient cohorts, augmenting real training data sets, whether they be small or unbalanced, with synthetic data to help improve predictive model performance, training predictive models with purely synthetic data, and then seeing how well they perform with actual real data. And also a sort of final potential use is to validate models or tools with synthetic data that were actually trained with or created with real data. And the idea here is to be able to validate perhaps on other healthcare institutions when you don't have access to that particular data. So there are many types of synthetic data. 2 major categories that I'll go over today with an example from each are sort of simulation-based synthetic data generators and machine learning-based synthetic data generators. For the simulation-based, I will concentrate on a tool called Synthea. So Synthea uses a publicly available summary statistics and manually created care maps to create a very sort of extensive simulation framework to create synthetic data. And the overall workflow is described in their previous publication and sort of outlined in this figure here. So they collect publicly available information from Health Institute statistics, from practice guidelines, and from medical coding dictionaries, and then create a simulation framework that includes patient profiles, diseases, comorbidities, and their prevalences. The actual care maps show sort of a trajectory of a patient through an incidence of care, and any sort of coded narratives that are appropriate for the model simulation framework. Putting all this together, they create sort of realistic synthetic electronic health records. And just an example of a care map, just to make this a little bit more concrete. The care maps are just consisting of several different nodes, which are put together in a sort of probabilistically sampled framework. So for example, you can start by sampling an age from a particular distribution, sampling a condition onset, given that age distribution, sampling an encounter based on that onset, and then perhaps prescribing a particular medication with a particular probabilistic frequency. And this is just like one submodule of many, and I'll show one more based on sort of our given case study in COVID-19 in a few minutes. The other side of synthetic data generators are those based in sort of more machine learning frameworks. And for this one, I'll use CorGAN, which is a modified generative adversarial network, or GAN, uses convolutional layers within the generator to better model relationships between groups. The intuition here is that using a sort of convolutional layers within a generator, within a GAN, can help you better model correlations between multiple different features. This is just a basic overview of CorGAN, which integrates the GAN with actually an autoencoder. The autoencoder portion is just to better mimic sort of binary and count data that is often found within electronic health record data, sort of adapting the continuous GAN framework to that binary and count data. But essentially, the major overview is just you need real input data for this particular method. So unlike Synthea, you're using real actual record level data. The first part of the GAN is the discriminator, which tries to tell the difference between the real data and data output from a generator, which is another neural network that you're training, inputs random noise and outputs data that looks like the real actual input generator. This framework is trained iteratively back and forth in an adversarial training procedure between the discriminator and the generator. And the generator, at the end of the day, is what you will use to create synthetic electronic health record data. For CorGAN in particular, this sort of approach has been shown, at least here, just showing the univariate feature frequencies within the real data and the data output by the generator, and is shown to have very high correlation between these features. So before jumping into the sort of quantitative analyses that we're going to use to compare these different synthetic data generators, I thought I'd start first with just sort of outlining a sort of qualitative comparison, and also just to give a little bit more context on both of the methods. So here just listed a bunch of different qualities and sort of ranked them for both Synthea, the simulation-based framework, and the CorGAN, the sort of GAN or machine learning-based framework. So in terms of privacy risk, since Synthea only relies on publicly available statistics and publicly available guidelines and dictionaries, the privacy risk to any individual patients is low. It doesn't access record level data at all. For CorGAN, as I said previously, it does require record level data in order to train the synthetic data generator. But as I'll show later, we can do a bunch of different privacy preserving validation metrics to show that the privacy risk to individuals, at least according to these metrics, is moderate to low. In terms of realism, because Synthea is a sort of simulation-based framework, the sort of realism of any given produced synthetic electronic health record data will be dependent on the level of detail and the accuracy in the probabilistic sort of modeling of that simulation. For CorGAN, as I'll show later too, because it's being trained on the basis of actual real record-based electronic health record data, realism tends to be fairly high. Also, both of these methods require at least some sort of setup and installation effort before you can actually generate synthetic electronic health record data. For Synthea, this involves creating those care maps that I showed sort of a submodule of. And depending on the complexity of the clinical situation being simulated, there can be quite a large, there has to be a large amount of investment in developing these synthetic care maps. For CorGAN, the input is essentially just a sort of matrix table. So the amount of setup effort is essentially being able to query whatever relational database in which the real electronic health record data lives, and creating that data matrix for a use case of interest. In terms of generalizability, because Synthea is based on this sometimes extremely complicated simulation framework, you can actually create sort of pseudo whole electronic health records with multiple tables be that visit encounters, medications, and patient profiles. So you can create a very sort of generalizable data framework. For CorGAN, because it relies on extracting a particular matrix of data, it's often, although not always, fairly limited to a particular use case that was in mind when creating that original data matrix on which the GAN was actually trained. And so the generalizability can be less than that for Synthea. Computational demand for a simulation framework is usually pretty low for Synthea. For CorGAN, because you are doing this iterative training procedure of this machine learning model, especially when you're using a large number of samples and a large feature space, the training computational demand can be higher. Just from basic experience, though, dealing with sort of these moderate-sized use cases with structured electronic health record data, the computational demand has not been unreasonable. I've been able to do it either sort of on Ray and the UCSF framework or on a laptop with a couple of cores. Again, just repeating sort of the required data for Synthea, only using publicly available statistics. CorGAN requires having access to record level electronic health record data. And again, for sort of the data formatting as it sort of comes out of these generators, for Synthea, you can generate sort of multiple tables in this full relational database framework, depending on the format of whatever simulation care map is designed. For CorGAN, at least at the moment, this is just a sort of matrix level input and output of that synthetic electronic health record data. So because of these different methodologies, there are many different aspects, as we showed just this qualitative analysis, on which Synthea and CorGAN differ. So we'll also look at a sort of quantitative comparison of these different methodologies, and we'll look at sort of three different sort of uses of synthetic data to do this quantitative comparison. First, we'll just look at some summary statistics, sort of looking at sort of the exploratory analysis of a given synthetic cohort. We'll also look at the use case of augmenting real training data sets with synthetic data. And then finally, we'll look at training and evaluating predictive models with synthetic data. We'll use 3 data sets, and I'll go over each one of them just to make sure, just because there's a lot of different dimensions in these analyses, just to list out everything here. These 3 data sets, for the real data set, we'll be using the Veterans Health Administration's COVID-19 shared data resource. This is just a consolidation of all patient data for individuals tested for COVID-19 within the Veterans Health Administration. And then for the synthetic data sets, we'll use a COVID-19 module that was developed by Synthea as synthetic data from the Synthea method. We'll also have a COVID-19 matrix derived from the VHA COVID-19 shared data resource to train a CorGAN model and generate synthetic data from that trained GAN model. So just to give a brief overview of the COVID-19 data resource in the Veterans Health Administration. So again, this is all patients tested within the VHA facilities for COVID-19. This is the vast majority of these individuals, because it is the Veterans Health Administration, are veterans, but there are some individuals tested within the VHA network who are not veterans. The data is extracted from the VHA's corporate data warehouse, somewhat similar to the UCSF clinical data warehouse. It's a consolidated data warehouse of all electronic health record data that's generated across the nation at all VHA facilities. And the data resource contains information including patient demographics and profiles, information on admissions, in particular for admissions due to COVID, hospital utilization, for example, how many times they visited the ED in the last year, and then a whole table is dedicated to conditions, medications, procedures, and symptoms that were exhibited by the patient before their testing date. And just to give you a little bit more summary information, so the COVID-19 data resource ranges from March 2020, when first cases started to appear and be tested within VHA, to the present. it's basically anybody tested for COVID-19 in the VHA, which as the last time we checked was over 1.2 million patients, quite a large cohort. The tables that we'll end up using are just these pre-indexed condition, medications, procedures, and symptoms, patient information, admissions. And we sort of stopped our query of this actual real database just for the sake of this analysis, but this is actually a weekly updated resource. This diagram is just the number of cases that are added to the shared data resource across time. And as you can see, this sort of tracks the national trends that we're seeing across the nation, with the sort of largest peak happening sort of late December, early January. So the Synthea data set, we're using the COVID-19 developed data map. And so the Synthea actually has a really interesting graphical user interface for creating these tier modules. They have a full web-based platform and tool where you can load core modules, submodules, and also sort of more complex modules they have hosted on their GitHub website. And this just makes it easier for individuals to design custom modules or to modify existing modules for their given case of interest. So just to give a sense and a flavor of how complicated this can become, here I'm just looking at the COVID-19 GitHub module where we'll be using this synthetic data. This COVID-19 module has several submodules, which in turn have several submodules. And here I'm just showing a drawing of part of the symptoms submodule of this COVID-19 submodule right here. So, so these modules can be extremely complicated and produce data that has commensurate complexity. They also published on this particular module recently. So if you want to read more about it, do that. So in order to make this sort of, in order to make the comparison easier, what we ended up doing is taking the original Synthea tables and translating them through some custom ETL procedure into data tables that resemble the real COVID data mart. And then from these COVID data mart like tables, all filled with Synthea-like data, we extracted a particular matrix to do a lot of our quantitative comparison metrics. This process is also because there was a couple of months ago, there was a FDA Precision Health Challenge using this COVID-19 Synthea dataset, where people developed models for, I believe, 4 or 5 different downstream COVID-19 outcomes. And the eventual goal is to be able to utilize the models that were built on the Synthea data and be able to test them out in real data to see how well they would work on the real data set when trained on synthetic data. For the CorGAN model, we had sort of a slightly different procedure. So using the real data tables from the COVID-19 data mart, we extracted a matrix based on a particular use case for an outcome and any given features for a predictive model that I'll describe in just a second. Using this matrix, we use this matrix of real data input to train a CorGAN model and then output from the generator a synthetic data matrix that we use in subsequent analyses. So first, I'll just go into the sort of exploratory analysis of the patient demographics. So just to show the weakest parts first, here I've shown distribution of ages. So this is age at the sort of case or index date when somebody was tested. For the real in green, the Synthea data matrix in sort of reddish, and the CorGAN model in purple. So I believe the Synthea data model looks like it was sort of sampled from a uniform distribution. The CorGAN model also does not do a really great job at all of replicating the distribution of ages. I believe from sort of some simulation studies across these sort of count variables, this is because we were using a sort of improper number of training epochs. I think if we could optimize the number of training epochs, we would neither underfit nor overfit the generator to the distribution, and probably, and in simulations have been shown to get a sort of better distribution with these count variables. But CorGAN does do better on categorical and binary variables for just looking at the distribution of sex in the database, again, using the same colors. sort of real and the CorGAN have the same numbers, are able to replicate the sort of same frequency of female to male, whereas Synthea is fairly equal across the distribution, given the sampling was equal within the simulation care map. In the real data, the distribution is highly distorted just because of the demographics of the veteran population, which overall, I believe at the moment, is about 10–12% female. Although this is the fastest growing demographic of veterans, just interesting to get. So in the end, we're going to do a predictive target outcome for transfer to the ICU, and this is just to show that we can do a fairly good job of simulating the frequency of our target outcome when creating a synthetic data set. This is especially true of the CorGAN data set, but also the sort of Synthea frequency, even though it's based on a completely separate simulation. Care map tends to map fairly well with the frequency of patients that are transferred to the ICU. Just a couple more summary demographics, but here we're looking at conditions and symptoms, and here we look at the for each defined condition, we map the real feature frequency or prevalence within the data set, and then just compare and contrast that to the synthetic feature frequency on the y-axis. So again, CorGAN does a very excellent job of mapping this univariate feature frequency, as sort of follows from previous results. For Synthea, many of the conditions have a sort of near zero frequency, and I believe this is just because we did sort of manual mapping of many of the sort of Synthea concepts to the condition concepts within the real data set. And just because it is a synthetic data set based on a simulation data care map, it just didn't have the same coverage and range of conditions as was present within the real data set. So that's why many of these conditions are at fairly low frequency. For symptoms, for CorGAN, we show some of the same sort of patterns of high correlation. For Synthea, it's kind of all over the board. And not to do this to death, but here's just for the procedures, of which there are very few and tend to map very well. Medications, the medication concepts seem to show the same sort of univariate feature relationships as with conditions, in that CorGAN tracks very well, but many of the medications that are present in the real data are just not present in the same depth of granularity or scope in the Synthea data set. So in order to sort of go into our augmentation and training a predictive model, quantitative assessments, we'll use the transfer to the ICU as a predictive model case study. So here, train a sort of real model with the VA COVID data mart, where our actual cohort, a subset of patients, are those that are admitted to the hospital and positive for a COVID-19 test, and veterans. Actually, we limited this to veterans only. Outcome again is transferred to the ICU, and for features we use demographics, the chronic conditions, symptoms, medications, healthcare utilization, many of the same features that we just talked about. Just did this very simply with a logistic regression model. We have a training sample size of about 75,000 patients. Again, we did this whole ETL procedure to map the Synthea data onto the COVID-19 data mart because we want to utilize the much more complicated models with much more elegant feature engineering that many people did as a product of this FDA precision challenge. And so again, this is not meant to be like a very good model. It's just meant to be able to compare and contrast these different synthetic data generators. So first, augmentation. So we just doubled, just did something very simple at first and just doubled the real training size by just adding synthetic data, adding synthetic data of the same size. And unfortunately, in this case, it doesn't seem to actually improve performance at all. I think perhaps if we had a much smaller sample size, then perhaps we would have seen more increased performance. But in this case, it did not, augmenting with synthetic data did not seem to increase performance. We also tried augmenting the minority outcomes with synthetic samples. So the percentage of patients transferred to the ICU is highly unbalanced. And so we tried just balancing the data set with respect to the target outcome by augmenting the minority labels that patients actually go to the ICU with outcomes that were with positive outcomes that were generated from CorGAN synthetic samples. So we just balanced that data set while retaining the actual data training size. Unfortunately, here either, the performance actually went down. So the real model with the unbalanced is shown in orange with an AUC of 0.73. For the CorGAN augmented, it actually went down a little bit, 0.68. So again, it would be interesting to see what would happen if this was a much smaller data set, but also it seems like we need to do a little bit more work on actually improving the quality of the CorGAN samples, perhaps to see increased performance. On better news, we also looked at the training models with purely synthetic data and then testing them on a real data set and comparing that performance to models trained within the real data. So here we have a model for the transfer to ICU prediction, trained on real data, tested on real data in green with an AUC of 0.75. We then trained a model with purely CorGAN data and we're able to recapitulate a little bit of, at least the majority of that performance with an AUC of 0.67. Unfortunately, with this very simplistic logistic regression model and very simple feature engineering, the Synthea data wasn't able to train a model that did much better than random on the real test set. So we're very curious to see if any of the models that people created in the context of this challenge will show any sort of increased performance. If not, then it would be very very disappointing in terms of the fact that Synthea might not be able to create trained models that that would be applicable out of the box on real test set, although it could still serve as an educational tool and a model development tool for feature engineering and designing algorithms for the actual format of a data set, even if you couldn't actually train the model in for a sort of accurate model on Synthea data. Similarly, we can also think of the use case where perhaps an individual has trained a model within their institution on data that they have, but want to see if that model that they've trained with real data would work on healthcare data from another institution. And so this could be a classic use case for synthetic data. So if a given researcher at one healthcare institution can't get access to real healthcare data at another institution, but could get access to the synthetic data, could they test the model they trained on their own institution's data on the synthetic data from that other healthcare institution to show if their model would actually be generalizable across healthcare institutions? So again, we see some of the sort of similar patterns in that the green again is sort of the real model tested on a real data set compared with the orange, which is a real model tested on CorGAN test set. And what's reassuring is that these AUCs are almost equivalent with the ROC curves overlapping, showing that with the CorGAN data set, it seems that you can evaluate your real model to a degree of accuracy that resembles that of testing it actually on a real test set. For Synthea, it's definitely not random, but the actual accuracy of the AUC that you get by testing on Synthea data is definitely lower than for real tested or for CorGAN. And finally, just a note of caution. I mean, so what many of these challenges do is allow you to test on real synthetic data, train on synthetic data and then test on the same sort of synthetic data. But in many cases, at least for these two synthetic data generators, it seems that testing a model trained on synthetic data on a test set of the same synthetic data seems to overestimate, sometimes dramatically, the performance of that synthetically trained model relative to how it would perform in real data. So for CorGAN, this isn't quite as dramatic. For a model trained on synthetic data from CorGAN and tested on here CorGAN in blue and the real test set in orange, you get a differential of about 0.9 in AUC. However, for Synthea, training a Synthea trained model on synthetic data widely overestimates the AUC for these synthetic data sets. So it is something to keep in mind that depending on the particular synthetic data generator, that whatever AUC you get by evaluating a synthetically trained model on a synthetic data set may be slightly, if not wildly, inflated. So finally, the sort of stuff we've been talking about so far has been all of these quantitative metrics on the idea of realism and how can you use synthetic data in a variety of different use cases. But of course, privacy is definitely the other side of the coin to realism, and we need to be able to check to ensure that whatever synthetic data we have generated is not compromising the privacy of patients within whatever training data set was used to generate the synthetic data. This is not so much of an issue for Synthea since it's using sort of summary statistics that are publicly available, but this is definitely an area of concern for models like CorGAN, which are trained on record level EHR data. So one of the sort of simplest things we can do is just compare nearest neighbors. So this means just looking at the pairwise distances between real and synthetic samples and comparing that to the distribution of real versus real samples. So for example, this is just a cartoon, but we can have some distribution of the distance to the nearest neighbor among pairs of real samples. And what we'd like to see is that the distribution of nearest neighbor distances among the real samples is somewhat resembles the distribution between real and synthetic samples. This is particularly true for CorGAN in the sense that the generator, if trained properly, is sort of sampling from the underlying distribution of all the different features within the real data set. And so when you're sampling from the generator, ideally what you're doing is sampling from the underlying distribution of real data. And so you would be sampling essentially other real samples or from that same space. And so these should overlap. What we really don't want to see though is the sort of pairwise distance of the nearest neighbors between real and synthetic samples hovering somewhere around 0. This would indicate that the generator is simply overfitting to the training data set and is now simply regurgitating the training data set, which of course would completely defeat the purpose of creating synthetic data since you're essentially just copying the real data set. So we ran this sort of nearest neighbor pairwise distance analysis between real and CorGAN samples just to look for these patterns. So we did sort of 4 different distributions of distances, again, between real and real, between real and synthetic, in this case being the CorGAN. We also did sort of like as a baseline, a sort of what we're calling a probabilistic matrix, where each of the features is just sampled from the actual frequency within the real data set. The idea here is to have a sort of less realistic synthetic data set, since it is just sort of random samplings on the marginal probabilities of each of these features. It's not taking any of the sort of correlations between these features into account. And then finally, as a sort of very, very bad synthetic baseline, we just sort of real versus a randomly sampled matrix where features are sampled between 0 and 1. And here's just showing those distributions in a graph. So the blue is the real versus real, orange is real versus synthetic, and as you can see, it's fortunately not having high density around 0, so it's not simply memorizing the data set. Overlaps fairly well with the real versus real pairwise distances, but is also slightly shifted to the right, indicating that the sort of real versus synthetic nearest neighbor distances are slightly more distant than real versus real, which, if anything, is what we would like to see, just to ensure that we're not copying or memorizing the training data set. Similar to that pattern, the sort of real versus probabilistic in green is slightly more to the right, and then the real versus random, of course, is way far out to the right, being the furthest distance from the real samples, as we would expect and hope. Another slightly more complicated metric we can use for privacy validation is in the context of membership inference, where here we're going to define membership inference as can you design a classifier or some way to use the synthetic data to determine if an individual of interest that for some reason you have their actual real data, could you use that synthetic data set to determine if that individual was in the actual original training data set that was used to train the synthetic data generator? This can compromise patients' privacy in multiple ways, but I think the most sort of intuitive example is if a synthetic data cohort was created on the basis of a sensitive condition, for example. If you could set up a classifier that would be able to use the synthetic data set to determine if an individual was in the original training set, then the sort of attacker would know that that individual had that sensitive condition, therefore compromising the individual's privacy. So there's been a lot of work on membership inference, not only in the context of synthetic data, but also on just releasing pre-trained models. And so there's many different ways to be able to assess this risk. For some of the synthetic data generators, CorGAN in particular, this is done really simply by just taking the synthetic data set, splitting the real data set before training the actual synthetic data generator. So you have a training data set and testing data set of real data, and then just calculating the pairwise distances between the synthetic samples and the training data set. Here, this is just a cartoon shown in dark blue are the training data set samples, and the sort of light blue being data set samples in the testing set. And here the idea is you can just design a classifier based on sort of the pairwise distance and draw a threshold and be able to determine with some probability that an individual was in the training data set simply by calculating the distance between the training data sample and the synthetic data sample. And so this sort of cartoon would be a sort of high membership inference risk because this training data set lies much closer in space to the synthetic data set than a sort of a separate testing sample of real data samples. So fortunately for this, I know this is a very boring plot, but it's a very encouraging plot. It does not seem with this framework that there's really any risk of membership inference, at least with this very sort of simplistic model of assessing membership inference risk. So definitely in the future, I think we can design membership inference risk scenarios that might sort of be much more sensitive to any sort of information in the synthetic data set. But at least for these simple discriminatory models based on the sort of distance, there does not seem to be that much risk. So just before wrapping up, I just wanted to I brainstorm a couple of different stakeholders and sort of user scenarios, and just wanted to sort of lay out a sort of first draft of a sort of user guide for particular different synthetic data generators. And this is just because we've gone through some of the qualitative and also quantitative sort of comparisons of these different synthetic data generators. They have their pros and cons and strengths and weaknesses. And so particular scenarios and use cases would be more amenable to particular synthetic data generators. So for the first set, sort of like students wanting to learn, teachers wanting to give data sets out for a sort of instructional class, or for hackathons, for example, these often depend on sort of being able to distribute to a large audience and having high generalizability to allow for sort of expansive scope of the challenge or sort of student learning experience or whatever instructional homework assignments or assignments or projects is given to the students. High realism is perhaps in these scenarios less important than just being able to have high generalizability and being able to distribute. So in this case, it's sort of Synthea might be a better option just because there is not so much of a dependence on high realism, and you wouldn't have to worry so much about any sort of privacy or regulatory constraints on the data set. For internal researchers, for example, internal researchers in another group who don't have IRB access or who are awaiting IRB access to a particular real data set. In this case, sort of high realism is extremely important, but it would have very sort of narrow scope of distribution. And usually there is, although not in all cases, but in many cases, there is a particular use case in mind, so high generalizability might not be as important. In those cases, CorGAN might be a really good option. For external researchers, the only difference would be perhaps you need a little bit more high generalizability, but because high realism would also for many research purposes be of the highest priority, CorGAN is probably also the best choice. For sort of sharing with commercial partners, again, high realism is extremely important. High generalizability might also be important depending on how well defined the actual use case or target business case is. In that case, it might depend on sort of the level of trust and partnership with these commercial partners, and so that might make the decision between CorGAN and Synthea. Just the last is a sort of like a purchaser of a given product within a healthcare institution or other institution. Many times these products are provided, are sort of advertised to healthcare institutions, but it would be great to be able to sort of validate that product before purchase on datasets that resemble the healthcare institution's dataset. So in that case, the sort of high realism is extremely important, and sort of CorGAN would be the best. So just to wrap up, in this presentation, it showed that you can train models with synthetic data sets without access to real data. Of course, the performance does not reach that of training with real data, but at least with CorGAN and machine learning-based synthetic data generators, you can get a reasonable amount of performance. At least in this particular use case, augmenting training sets did not improve predictive model performance. This could be for a variety of reasons. It may also be just because our training data set in real data was actually fairly large at 75,000 patients already. For one further step to try would be to see if the augmentation would work better if we sort of started out with a smaller sample size in the real data set. The GAN-based models in many of the quantitative metrics seem to show greater realism than simulation-based models, but at the same time do not seem to substantially, at least with some of the privacy checks that we've done, compromise privacy of individuals within the training data set. But finally, for many use cases and stakeholders, having generalizability of the given data set is more important in some cases than actual realism. And in that case, the simulation-based models seem to be a better fit. For ongoing work, I'm continuing this collaboration with the Veterans Health Administration. They've recently purchased a commercial product for synthetic electronic health record data called MD-Clone. And so I've been insisting in sort of the installation of that product within the VHA, with the overarching goal of being able to compare not only these open source models, CorGAN and Synthea, but also a commercial product like MD-Clone in a fair and transparent benchmark. As I think I mentioned, we're also working on porting some of these models that were developed on Synthea in this challenge hackathon in order to validate them on actual real data to see if this sort of challenge framework using this challenge hackathon framework using synthetic data developed models can help build models that actually have validity in real data. And basically the whole point of all of this is to create a sort of benchmarking framework to validate and directly compare many of these different synthetic data generators in a sort of open, transparent framework. With that, I'd just like to thank you all for your attention, and also thank all of my colleagues in the Innovate for Health, UCSF, Veterans Health Administration, and UC Berkeley, and to thank Johnson & Johnson for funding this work through the Innovate for Health program. So thanks so much, and I'll take any questions.
Round of applause for Dr. Hunter-Zinck for a great presentation. At this time, we welcome your questions and comments. Please feel free to write them down on the Q&A portal, and I will present your question or comment to Dr. Hunter-Zinck. Any questions or comments for our presenter? I don't see any. I think you answered everyone's questions during your presentation. Any burning questions?
Awesome.
Yeah. Oh, we have a
Well,
just a commendation. Great work, Haley. Great presentation.
awesome. Thank you. Well, if anybody thinks of anything later or any comments or critiques or suggestions or anything, feel free to email me. I think my email is on the BIDS website, so feel free to contact me anytime.
I do know that there is some interest in collaboration, so I will put you in touch with some of the attendees. But if there's no questions for our presenter, I will give everyone 11 minutes back. And again, another round of applause for Dr. Hunter-Zinck for a great presentation.
Thank you so much.